a bit, and you understand the healthcare across the board around the nation. What is it you will say we are doing wrong that has not enabled us to reduce drastically the infant mortality rate?
Thank you. Let us start with Lagos. I think the commissioner has spoken about the PHC, that's primary health centers, the secondary, that's general hospital. But he hasn't talked about what happens in the rural area, where you have birth attendants, where you have people they call true. Those are people who are training. Yes, they've been working very well. Even medical students are sent to go and see what they are doing when they are in medical schools. They form important part of reduction in maternal mortality. How? They must be supervised. They must be retrained because they form a very vital part. The people in rural area believe in them. They go to them first and foremost before going to even the primary health care, primary health center. When you train these people to know when to stop, when to push forward their cases, and not to wait until the last minute, because you know the traffic situation in Lagos, you know every other conditions we have. Don't let us talk about NEPA, about overtime, about anything. They must be told and be encouraged to refer their cases, which they believe and they know they may not be able to handle, quickly to the primary health center. The primary health center, of course, are staffed by doctors and midwives and everything. They also are being told not to waste time, because we're talking about baby in utero, and who could die within minutes, 30 minutes, 1 hour, gone. They must also refer. See, this referral, the commissioner and myself were discussing about it when we started. It is very important. It is one aspect that reduces death. If you can get help in time, you might save life. But if you don't get to the place where there is help, the life is lost.
In other parts of the world, there is processes and procedures, and you know at what point you have to escalate and you've got to move the case on.
Yes.
And those procedures are lifesavers more often than not, because when you get to a certain level, you know that you must quickly move this patient to another hospital or get a consultant in or get a registrar in what level of service that is required. Do we have that in our hospitals in Nigeria?
Yes, and it's an inbuilt training for all doctors, because it's a teamwork to know when to stop and when to transfer. And the doctor must be sanctioned if he delays unnecessarily.
Are there sanctions in place, and what sanctions are there?
Yes, there are sanctions in place. Whether they are enforced very well, but another matter because of Nigerian situation of family ties, long legs and everything. But there are
long legs.
Yes. there are really sanctions. Even when I was a junior doctor 40 years ago, 45 years ago, there were sanctions. You cannot toy with the lives of your patient, because you are sworn to protect that life to the end. And you must know where your ability, considering the availability of equipment and everything, where it stops. You must know. Even if it means getting into a old car with that patient and driving to the next center of attention, you must do it. Don't wait for the ambulance. There must be that commitment, that knowledge of all doctors who are practicing, because, as I said, it's a teamwork. You must now, with the aid of the GSM, inform the people you are going to see that we are coming. This is the type of case I have, so that they will prepare for you. This is very, very vital. At one time in Lagos, when I was in Natal Maternity in 1974, people were being referred from Epe, from Ikorodu, from Badagry, on those atrocious roads. Most of them will come with burst uteruses. They are dead before they came. That was one of the conditions we fought, the military government at that time for, because they don't seem to understand what we are saying. That please scatter these hospitals to everything. We have them now. At that time, it was as if we had something in mind when we were telling them to open those hospitals. That you must make sure that people can get to where help is necessary and can be found.
Nearer to them.
Nearer to them. All right. Regardless, and I'm sure the commissioner is going to take this on of our situation in Lagos. Lagos population keeps on increasing. All these statistics that they are bandying around, 18, 20 million, it's not stable. How many people enter into Lagos every day? It must be more than 10,000. And politically, I have raised this up with the governor. Politically, he cannot stop it. He cannot prevent it. He must just cope with it. Yes, he told me that, and I agree. And I said, look, we must face it. So we have this problem. How do we save lives? The cost is enormous, but we must go for it.
So if we ask, you wanted to ask?
Yes, Doctor. The issue of money is very important in keeping people staying alive. Yeah. I know that a lot of women don't go to these healthcare centers or hospitals because they can't afford to give birth in those places. So they'd rather stay at home and have the traditional, the TBAs come and deal with them at home. So about how much is it for a woman to give birth in a government hospital?
Well, let me answer. This is a fact. Different hospitals charge different amounts of money for the same procedure.
Okay.
What is charged at the private level is about 3-4 times higher than what is charged at the public hospitals.
Okay.
Because it's a public hospital, it's government responsibility. The tenants you charge very low. But again, like he did say, you have a huge number of people. People say health is a right. Government must protect that right. And that's why previous governments, they initiated this free health scheme, which in Lagos State is what we've been trying to do. But again, with all the challenges we have, the resources that we have are totally, inadequate. And it's like you have to build all these facilities that you are using to increase access. You don't consider the facilities, spread them out, build them differently to ensure that people don't have to move far distances. Like it says, so many poor people who cannot even afford us in charge. And that's why the government has said, okay, free health is an attempt to address the issue of those poor people who cannot have access to health. And if you are poor, your health is down. It's more like a vicious cycle. That's an attempt. But again, the reality is that you can't sustain this free health. Because what is required,
do we have free health system in Nigeria? Not only in Lagos, do we have free health care in Nigeria at all?
A number of states who do, it's not totally free. Somebody is picking up the tab. But again, depending on resources available to you, you can't have everything free. Take for instance, you're building the facilities, you're staffing, you're equipping, you're buying the consumables, you're even paying running costs to those hospitals. But again, you see, expect that when the people come, they should be treated free. That's huge. But again, that's why in the previous episode we try to narrow down this scheme to specific population of people.
So if you want to be specific, we do not have free healthcare in Nigeria. It doesn't exist.
We have some form or the other, yes.
But we don't have free
healthcare.
Can I come into this?
Because I am not political at all. I want to...
So we're likely to get the truth out of it.
Yes. There is no free something. No free healthcare.
No free healthcare in Nigeria at all.
Not really. The action group of the past, SDP, they want to spread welfare to everybody by saying that it's free health, free education. But they have to provide for those things from their budget. And in doing so, right, they are using money to be used for other things for the health of people. So they say it's free health. You will then see that when they even go there and think it's free, they will still buy other things which are not available, which the hospitals don't have. So it is a good thing to have that intention. The mind is willing.